right, why don't we go ahead and get started? So we have 6 presentations, each of 10 minutes, and there'll be 2 minutes for question and answer. This is a very supportive forum, so presenters, put your fear aside. And let's start with C. Abigail Temple, or Abby Temple, who will be talking about the time from hospital presentation to head imaging in Black, white, and Hispanic geriatric patients.
Perfect. Let me get my slides pulled up here.
Great.
Thank you so much for having me, by the way. All right. Can everyone see my screen?
Perfect.
All right, perfect. All righty, so good afternoon, everyone. So as was said earlier, my name is Abby Temple. I am a third-year medical student at Charles E. Schmidt College of Medicine at Florida Atlantic University. And today I'll be presenting a project on time from hospital presentation to head imaging in white, Black, and Hispanic geriatric trauma patients. So these are the individuals that I worked with on this project, and I have no conflicts to disclose. So unfortunately, healthcare disparities have been shown to negatively affect non-white people sustaining trauma, leading to increased morbidity and mortality in these minority populations. One possible explanation for this disparity in outcomes could be delays in emergent medical care. The time to head CT for a head injured patient is an important metric in determining outcomes of intracranial hemorrhage, as more rapid diagnosis of a head bleed can lead to more rapid treatment and better outcomes in patients. So the objective of our study was to assess if a disparity exists between races among acutely head injured geriatric patients. And we determined this by subtracting the time of ED presentations to the time of CT performance. Our study was a prospective observational study conducted at 2 level 1 trauma centers in South Florida. Between August of 2019 and May of 2020, patients 65 years and older with head injuries were identified daily by either ICD-10 diagnosis of head injury or head CT performed for the purposes of trauma. Research assistants screened patients for enrollment by reviewing, oh no, it says sharing's paused. Can you guys see it? Sorry.
Yes, we can see.
Okay, sorry. It like popped up with a thing that said sharing was paused. Okay, sorry. So we had research assistants screen patients for enrollment by reviewing the physician's notes in the EMR. And we excluded any patients with multiple or unknown races or ethnicities, and patients with any penetrating head injuries, transfers from other facilities, and patients who had injuries greater than 24 hours prior to presentation. So, as I said before, our primary outcome was time from ED presentation to head CT performance, and this was compared between white, Black, and Hispanic groups using ANOVA analysis. We also collected additional variables from the charts to account for any potential confounding variables. And so these included the presence of primary intracranial hemorrhage, which was defined as acute hemorrhage read on the CT scan by the attending radiologist. We also looked at trauma status, which was whether or not there was trauma activation by EMS if the patient was brought in via ambulance. We looked at reason for head CT, so whether there was definite head trauma reported in the history or just suspected head trauma. We also looked at physical exam findings, so whether or not there was evidence of head trauma on physical exam or not. And then we also looked at GCS category. And so we split it into mild, which was a GCS of 14 to 15, moderate, a GCS of 9 to 13, and severe, a GCS of 3 to 8. So overall, we screened 4,959 patients, and then of these patients, 3,759 patients met our inclusion criteria. 300 were excluded due to unknown race or ethnicity and or having multiple races or ethnicities listed. So of the patients included, the majority of our patients were white, accounting for approximately 89% of our study population. 5% were Black, 4% were Hispanic, and 1% were classified as other, which included Asian, Native American, and Pacific Islander races. So in the third column on this table, you can see that the mean time to CT for each race and its confidence interval. So overall, what we saw was that Hispanic and other races or ethnicities trended towards a faster time to CT. Whites averaged 90 minutes to CT, and Blacks trended the highest time to CT, waiting 97 minutes on average. So when comparing all the groups to each other, the overall time to head CT was 91 minutes. When comparing all of the groups to each other, there was no significant difference found as denoted by our P and F values. We then compared each group to a combined others, so white versus non-white, Black versus non-Black, and Hispanic versus non-Hispanic. We did not find any significant differences between these groups either. When analyzing the additional variables that I discussed earlier, we did not find any significant differences between the groups with any of the variables. So not with trauma activation status, GCS grouping, signs of head trauma, reason for head CT, or head CT positive for acute intracranial hemorrhage on CT. So what the data tells us is that in this population, there was no significant difference between time from emergency department registration to CT performance between white, Black, and Hispanic individuals. And that this observation remained true when controlling for the presence of primary intracranial hemorrhage on CT, their trauma status, their reason for their head CT, their physical exam findings, and their GCS categories. However, it is important to note that Black individuals did trend towards longer time to CT than their non-Black counterparts. And this difference was approaching significance with a p-value of 0.089. This lack of statistical significance could have been due to the small number of Black patients in this study. However, while enrolling more Black patients may make the findings statistically significant, it's still unclear if a few minute difference in identification of the intracranial hemorrhage is clinically significant regarding patient outcomes. So, you know, the difference between our white patients and our Black patients, it was a difference of 7 minutes. So even if we had a higher population of Black patients, the question begs, like, is the difference in 7 minutes clinically significant enough to denote real, like, impact on how we practice medicine? So based on all of our data, our final conclusion of this study was that while we know racial disparities in outcomes of head trauma patients exist, it does not appear to be due to differences in time to CT performance. But thank you all for listening. I would now gladly take any questions, and my email is on the slide too, if you guys would feel more comfortable emailing me questions and I can respond. Thank you.
Thank you, Abby, for that presentation. Very, very well done. Does anybody have any questions for Abby? So I think this is a great study. I think that recent studies have shown a lot of differences in treatment based on race and based on ethnicity. And I think this is one case where you didn't find a statistically significant difference. I know you mentioned that you had a small percentage of Black patients. I can say it's much smaller than our patient population. But I think your point about clinical versus statistical significance is really important, because while we always look at statistical significance, what we really care about is the clinical significance. And so I thank you for bringing that up. I think, are there any other reasons why you maybe think you didn't find a difference in time to CT when other studies have shown differences in clinical outcomes?
Yeah, absolutely. I mean, like I discussed earlier, there are a lot of factors that go into, you know, when a patient is seen and how quickly they're seen. And there were previous studies that have shown that Black patients waited longer in the emergency department. But and so, you know, there could be factors with that, but that was kind of the idea behind why we looked at time to CT with head outcomes, just kind of seeing if that translated over to like access to care as well. Mm-hmm.
One of the things I thought about was CT in elderly patients is somewhat algorithmic, right? We know based on clinical guidelines that, you know, people over 65, you get a head CT. So I'm wondering if that takes away some of the, what you might call unconscious bias. And I wonder if you look at some other metric other than something that is very kind of algorithmic, I wonder if we might find a difference.
Absolutely, it's a great point. Definitely look into that.
I wonder if there's a difference in time to CT being ordered, for example.
Yeah, although you think that would figure it in, that would also figure in with the time till the CT was done, because the earlier it's ordered, the earlier it would be done. but that's a good question too. Probably something that's easy to look at as well.
Yeah, true.
All right. Well, thank you very much. Great presentation. Now, if you'll stop sharing your screen, we will next invite Dr. Charlene Schwann to share her screen.
Thank you guys again.
Thank you. So my name is Charlene Schwann, and I'm an assistant professor in the Department of Health Policy and Administration at Penn State University. And I have no disclosures to make. So previous literature suggests that ED patients who have Medicaid or no insurance are more likely to be transferred from the ED as compared to privately insured patients, although this can vary by condition. And ED patients who are Black and Hispanic are generally not transferred out at different rates than patients who are white. Although other studies have, other than what Abby just said, they have suggested that Black patients may be more likely to experience inappropriate delays. So the study over here was looking at, suggested that Black patients are transferred more slowly to revascularization hospitals after AMI compared to white patients, even within the same hospital. And as most of you know, EMTALA is a Medicare condition of participation that states that Medicare participating hospitals can't transfer unstable patients with an emergency medical condition based on race and ethnicity or payer. But EMTALA does not require a specific receiving hospital, nor does it apply to stable transfers. So our research question was whether Black and Hispanic patients are more likely to be transferred to public hospitals compared to white patients, and if so, under what conditions? To look at this, we conducted a descriptive study using Florida inpatient and emergency department data from HCUP 2015 to 2018, which we matched to the American Hospital Association Annual Survey for Hospital Characteristics. Our sample consisted of adult ED patients transferred to other acute care hospitals within Florida, and we defined a transfer as a visit to another hospital the same day or the next day within 8 hours. So the important thing to note about this is that this definition includes both formal transfers and also indirect referrals. We then looked at 4 different outcomes by race and ethnicity. First, we looked at the percent of patients who were transferred to receiving hospitals of different ownership types, the percent of patients who were transferred with conditions likely to be of high acuity, which we defined using CPT codes, the percent of transfer patients who were admitted by the receiving hospital, and of the transfer patients who were not admitted by the receiving hospital, the percent who revisited the emergency department within 3 days of discharge. We then stratified results by the ownership type of the receiving hospital and also the race ethnicity by payer, meaning we compared, for instance, a Black patient with Medicaid with a white patient with Medicaid. Because of our large sample, we found a lot of differences between between patients of different races. Compared to patients who are white, Black and Hispanic patients have a lower comorbidity burden. They're younger and less likely to come on the weekend. And they also had different payers compared to white patients. So this graph shows the difference in the percent of patients who are transferred to hospitals of different ownership and compared to white patients. The bars to the right show that Black, Hispanic, and Asian patients are significantly more likely to be transferred to public hospitals compared to private hospitals. And more specifically, Black patients are 6.6 percentage points or 67% more likely to be transferred to public hospitals. Hispanic patients are 8.6 percentage points or 88% more likely to be transferred to public hospitals. And Asian patients were 5.8 percentage points or 60% more likely to be transferred to public hospitals. The takeaway point is just that minority patients are more likely to be transferred to public hospitals. We saw the same results when we stratified based on payer and race. When we looked at the percent of transferred patients with high acuity conditions, we found that that Black and Hispanic transfer patients were less likely to have a high acuity condition. Specifically, patients who are Black compared to those who are white had 12.3 percentage points, were 12.3 percentage points less likely, or 16% less likely to have a high acuity condition. Those who were Hispanic were 7.1 percentage points or 9% less. And other was 13.7 percentage point or 18% less. Patients who were Asian were 3.7 percentage points more likely or 4.9% more likely to have a high acuity condition. And when we looked at this by race and payer, we saw the same trends. When we looked at the percent of transferred patients admitted by the receiving hospital, we found that Black and Hispanic patients were less likely to be admitted by receiving hospitals compared to white patients, and Asian patients were more likely to be admitted. Specifically, Black patients were 17 percentage points or 30% less likely to be admitted. Hispanic patients were 11 percentage points or 18% less likely, and Asian patients were 6.1 percentage points or 10% less likely. And the trend was the same regardless of the ownership type. So again, takeaway point is just that receiving hospitals are less likely to admit Black and Hispanic transfer patients. And this was consistent even when we looked at race and payer. Among the transfer patients not admitted, we then looked at the percentage of patients with an ED revisit within 3 days. And what we found was that among patients who were not admitted by the receiving hospital, minority patients are less likely to revisit the ED. And this was 1.7 percentage points for Black patients, or negative 12%, 1.4 percentage points, or a 10% difference for Hispanic patients. And then for Asian and other, it was negative 2.8 percentage points, or 19% less. And we found this was consistent even when we looked at patients by both race and payer. So in conclusion, compared to white patients, Black and Hispanic transfer patients were more likely to be transferred to public hospitals, less likely to have a high acuity condition, less likely to be admitted by the receiving hospital, and if not admitted by the receiving hospital, they were less likely to revisit the ED within 3 days. And we saw the same pattern by race and payer. This suggests that Black and Hispanic patients are more likely to have ED transfers for conditions that are likely of lower acuity. So there may be lots of reasons for this. So it could be geography. So Black and Hispanic patients, for instance, may be more likely to live closer to public hospitals, although this doesn't explain the acuity results. It could also be that public hospitals may offer different services than are offered by the non-public public hospitals, and that Black and Hispanic patients might have greater need for those specific services. Although again, our results are still interesting because of the low acuity findings. Another possible reason for our findings was indirect referrals. So you'll recall that our study includes both direct transfers and also indirect referrals. So maybe Black and Hispanic patients are more likely to go to another hospital to get a second opinion. Although if that's the case, then we would expect to see a difference by payer, particularly patients who are uninsured. You would expect that patients who are uninsured would be less likely to try to get the second opinion. And we see consistent results regardless of whether we adjust, regardless of the payer. And then one other possibility is structural racism. So previous research suggests that Black patients are more likely to be transported by EMS to public hospitals compared to white patients living in the same zip codes. It's possible that that patients themselves and perhaps hospitals and EMS all consider public hospitals to be, more of the hospitals for the minority patients, or so that they're the hospitals that serve the minority patients. So they're more likely to send them to those hospitals, even if the transfer is of low acuity. So our limitations are, this is a descriptive study, so we don't control for possible confounders. We definitely need to do more research to find out the reasons why. It may have limited generalizability because this is only for Florida, although we've done some initial work in California and suggest that we find the same results. So our findings are concerning on a policy level because they suggest that public hospitals may be burdened by lower acuity transfers that may strain hospital resources, and that this might be particularly important if we start thinking about how the lower acuity transfers may contribute to ED crowding, which public hospitals are already struggling with. I want to thank my co-authors and the funders. And thank you. And if anyone has any questions, I'd be happy to take them.
Great presentation, Dr. Schwan. I think the strength of this is that it is a very large database in an area, and you looked at direct referrals or formal referrals as well as indirect referrals. And I think that is super interesting because I know I'm at a public hospital and we often will get patients that come in saying, oh yeah, I was sent over by such and such a hospital. And so this was not a formal transfer, but yet it was still a referral. So I think this is great research. One of my questions is, and you may have already said this, but did you control for the confounder of insurance and race? In other words, you found that Black patients were more likely to be transferred for lower acuity. Is that perhaps because there was a different insurance status for them, or is there a way that you can control for that in your analysis?
Yeah, so we found the same results regardless of what, even if we're comparing white patients with, say, Medicaid versus Black patients with Medicaid,
Okay.
white patients with private, Black patients with private, et cetera. We found all the same trends. I do want to emphasize, right, that we didn't control for anything because this is not,
Right.
this is just a descriptive.
Understood.
But yeah, it was pretty striking how the trends were consistent regardless of payer.
Yeah. What other questions does the audience have for Dr. Schwan?
I had a quick question. This may be more of like a next step, but looking at who's admitted and for what kinds of conditions that they're admitted for, like differences for like the higher acuity conditions, for example. Are you guys planning to look, since you have those data, planning to look at the differences in those rates matched for a condition acuity?
Yeah, so we are planning on or hoping to do an adjusted analysis and look specifically at the conditions. There could be differences with, I mean, the one thing that pops into mind is, for instance, like trauma. Like I might expect to see a difference in trauma, and we don't know the extent to which that's driving our results right now. One thing which I think is interesting, though, is I did look at, for instance, mortality, and you see that white patients who are transferred are more likely to die than Black patients, which seems to follow the idea of that it's the higher acuity, that white patients are being transferred at higher acuity than Black and Hispanic patients are.
Mm-hmm.
Thank you.
Well, thank you very much.
Thank you.
Next up, we have Ms. Nida Reddy, and she will be speaking on race, ethnicity, inequities, and ED post-overdose care. And Nida, why don't you share your screen with us?
Yeah. Okay, is that visible?
It is. I'm sorry, I
Okay.
said Nida, it's Neha. Sorry about that.
No worries at all. Okay, so hi everyone. My name is Neha Reddy, and I'm a rising third-year medical student at Brown University. I'll be presenting our research project entitled Race, Ethnicity, Inequities in Emergency Department Post-Overdose Care. This study was funded by a Rhode Island Foundation medical research grant that was given to Dr. Samuels. It is a sub-analysis of a larger project looking at post-overdose services provision in our healthcare system. And we have no conflicts of interest to disclose. Emergency department visits for opioid overdose continue to rise across the country. Rates of overdose death, particularly those due to synthetic opioids and heroin, have disproportionately increased among racial and ethnic minorities, particularly among Black, Latinx, and American Indian Alaskan Native communities. There are known barriers in access to treatment, both in emergency departments and in community-based treatment programs. ED visits for overdose represent crucial opportunities to connect patients to treatment services. Since 2014, the Lifespan Opioid Overdose Prevention, or LOOP program, has been providing patients in Rhode Island EDs treated for opioid overdose with take-home naloxone, behavioral counseling with a peer recovery specialist, initiation of buprenorphine, and linkage to treatment. Past studies, such as the last one listed here, have demonstrated feasibility, acceptance, and utilization of this program by ED clinicians and patients. What we don't know, however, is if there are disparities in services offered to patients based on race and ethnicity. And so our study question was, are there differences in provision of take-home naloxone, behavioral counseling, and referral to treatment among ED patients treated during their first visit for an opioid overdose based on race and ethnicity? So in terms of methods, this was an observational cross-sectional study conducted at 2 Rhode Island academic hospital EDs that together see the majority of annual visits for opioid overdose in the state. Data was collected between September 2017 and February 2020. Participants were patients presenting to the ED for their first overdose, categorized by race and ethnicity. We created the following combined race ethnicity categories: white non-Latinx, Black non-Latinx, other non-Latinx, and Latinx patients of any race. Outcomes of interest were provision of take-home naloxone, behavioral counseling, and linkage to addiction treatment. We did not include initiation of buprenorphine in this study due to limited data on associated patient race and ethnicity. And finally, we ran chi-squared and multivariable logistic regression analyses to determine if there were differences in receipt of post-overdose services between race ethnicity after adjusting for patient, provider, and institutional level factors. So in total, there were 734 patients included in this study sample, 70% of whom were male. 70% of patients were white non-Latinx, followed by 18% Latinx and 9% Black non-Latinx patients. We also want to note the low number of patients in the other non-Latinx group. Nearly half of patients had public insurance and 14% were uninsured. So across the time period of our study, we found that take-home naloxone rates were the highest and most consistent across all race ethnicity groups. This was followed by referral to treatment, which increased across the study period, interestingly. And meanwhile, behavioral counseling rates were the lowest across all race ethnicity groups and actually decreased over the course of the study period. Our multivariate regression analysis adjusted for patient, provider, and institutional level factors. We found that there were no statistically significant differences in proportions of take-home naloxone or treatment referral based on patient race ethnicity. However, the odds of receiving behavioral counseling were significantly higher for non-Black patients. White non-Latinx patients had 1.75 times higher odds, Latinx patients had 2 times higher odds, and other non-Latinx patients had more than 3 times higher odds of receiving behavioral counseling with a peer recovery specialist. So this study found that most patients received take-home naloxone, as I mentioned. This may stem from availability and ease of distribution of naloxone within ED settings, particularly those with protocols in place to do so, as well as patient and provider acceptance of naloxone distribution as an important harm reduction strategy. Conversely, behavioral counseling rates were significantly lower among Black patients. There are both provider and patient level possible causative factors for this association. Providers may have implicit biases or more overt forms of discrimination towards patients with substance use histories or patients from different race ethnicity backgrounds. Linking patients to behavioral counseling may also be time intensive, especially for providers with competing demands, as it requires consultation of peer recovery specialists. Furthermore, providers may have limited training and strategies such as motivational interviewing. For patients, past experiences with behavioral counseling may influence the likelihood to accept services. Additionally, patient-provider concordance, particularly along race and ethnicity, has been shown to play an important role in willingness to receive healthcare services. Finally, many communities of color, especially Black patients, experience mistrust of healthcare institutions, which may limit their interest in engaging in long-term care. Behavioral counseling has been shown to be an important component of holistic treatment for opioid use disorder, particularly alongside medication. Therefore, this disparity puts Black patients at risk of worse health outcomes and future overdose potentially. Overall, this finding may add to known racial disparities in emergency care, including treatment of acute pain, traumatic brain injury, cardiac care, stroke care, and sepsis, all of which there is extensive literature for. So in terms of limitation, there are multiple limitations in this study. All data was limited to information recorded in the EHR, which may result in misclassification or selection bias. Obtaining demographic data related to race ethnicity is limited to categories listed within the EHR, which does not always reflect the true nuances and variability of racial and ethnic identities. Furthermore, there were low numbers of patients in some demographic groups, particularly other non-Latinx. Finally, this study was limited to 2 hospitals within one state. It may not be generalizable to EDs in other states, those with more diverse patient and provider populations or non-academic centers. So in terms of future directions, more research is necessary to replicate this study in other sites and to more clearly elucidate causative factors for racial disparities in post-overdose care. There's a general need for protocolized care to improve implementation practices and reduce biases in care delivery. Finally, the Rhode Island Hospital Emergency Department recently launched a community health worker peer recovery specialist initiative to make behavioral counseling and peer recovery support more readily accessible, particularly from staff who have lived experiences with opioid use and who are from diverse race and ethnicity backgrounds. And these are some of the references used. And thank you very much. I'm happy to take any questions at this time.
Thank you, Neha, for that presentation. That was beautiful. I think this does add to some of the literature we already have, which speaks about disparities in care based on race and ethnicity. My question to you is, it seems that you did not find a disparity where things are sort of more protocolized, like, okay, here's our protocol. We give naloxone to people when they leave and referral to treatment. But my question to you is more about the behavioral counseling part. Is that behavioral counseling in the ED or when they leave the ED? And is that something that is part of your protocol or readily available?
Yeah, so it's behavioral counseling within the emergency department itself. And that CHW program that I mentioned that recently got implemented is aiming to make peer recovery counseling more readily accessible. But we definitely acknowledge that that is one of the major limitations of trying to deliver behavioral counseling in an emergency department setting when it is so busy and there are so many competing demands and everything.
So prior to your program, was it the provider that would have to document that behavioral counseling, or who was it who documented that behavioral counseling that you were looking for prior to your peer support group?
That's a good question, Dr. Samuel, since you've been
You can
around.
phone a friend. You can phone a friend.
Yeah.
Okay.
Phone a friend.
So there was a community-based peer recovery coach program that we utilized before. The new program is ED based, so they're stationed in the ED. So there is this kind of lag time where you call someone. The provider will say, do you want to talk to somebody? And then they call someone who then has to come in. That's some of the. It's also protocolized, but there is a gap there that where the someone has to come in from outside.
So there's your next study. Does implementation of a in-house peer support program get rid of these disparities? Great research. And Neha, sorry, I did not mean to ask a difficult question, but you did fabulously answering. Okay. Our next speaker will be Caleb Carroll. I hope I said that right. And this research project is entitled Quality of Life Indices, Impact of ED-Initiated Medication and Follow-Up Care Linkage for OUD.
Yes, ma'am. Hello, everybody. My name is Caleb Carroll. I'm an MS3, a third-year med student at UAB. Thank y'all for having me on today. My mentor, Dr. Walter, unfortunately was not able to make it, but hopefully I'll be able to fly solo. So we'll go ahead and get started. As Ms. Linden said, my abstract is Quality of Life Indices, Impact of Emergency Department Initiated Medication and Care Linkage for Opioid Use Disorder, and they're the authors below. And just a quick disclosure, we do not have any relevant financial or commercial relationships within the past year. So the intro. So as most emergency room physicians understand, and as we kind of just saw in the past presentation, opioid use disorder is a huge problem. And just some numbers to kind of contextualize that. Since 1999, there have been over 500,000 deaths from opioid-related overdoses. And to put that in the context of an emergency room, after a admission for a opioid overdose in the emergency room, 1 in 20 patients subsequently die from another opioid overdose within 1 year. So there's a problem after being admitted into the emergency room. And to put this more in the context of the current climate of COVID-19, we have seen the highest to date 12-month period of deaths during COVID-19 from June 2019 to May 2020 than we have in history. So this is, of course, very relevant right now as well. So we wanted to kind of circle back and look at kind of some other factors actually affecting opioid use disorder and the deaths associated with that, especially with such a high rate of reuse and subsequent overdose. And so what we want to look at is actually quality of life factors. And as defined by the World Health Organization, quality of life is an individual's perception of their position in life in the context of the culture and value systems in which they live and in relation to their goals, expectations, standards, and concerns. And why is this relevant? Is that substance use disorders have demonstrated negative impact on quality of life factors in affected individuals. It affects their physical and mental health. It affects interpersonal relationships, employment, residential status. And so quality of life is being recognized increasingly as an important consideration in substance abuse research and clinical practice and treatment. And so it's been shown that non-emergency department initiated medication for opioid use disorder has positive effects on quality of life factors. But of course, this is an emergency medicine conference. We want to see how this actually affects, how emergency department initiated MOUD affects quality of life. We already know that ED MOUD is effective. It's emerged as an effective treatment strategy for opioid use disorder. In fact, OUD patients undergoing MOUD have higher retention rates, have higher success for greater than 1 year past the initiation of their treatment. So what we wanted to do to sum it up is assess, is our treatment as emergency department initiated MOUD correlated with improved quality of life factors? So on to the methods. So this is a SAMHSA funded project. It launched in July 2019. And after that, we referred to definitive services. The data that we are considering is 18 months worth of data from patients enrolled from July 2019 to December 2020. The structure of the study was that we interviewed these patients at intake, at 3 months, and at 6 months follow-up to assess their quality of life factors that are determined by the Government Performance and Results Act measures, the GPRA. And to assess this data, we use descriptive statistics and Fisher's exact. And so these are some of the GPRA quality of life indices that we looked at. On the subjective side, which was more personal, emotional factors, we had self-satisfaction, interpersonal relationships, overall health self-rating, quality of life self-rating, family and friend support, energy for life, and violence exposure. Whereas the objective side, the more concrete, non-emotional factors, we had housing, education, employment, and financial needs met. And so here are our results. So despite the pandemic, we managed to enroll 89 patients. A majority of those were white, male, and relatively young, about 25 to 44 years old. And you can see the rest of our demographics on our table here. And to date, we've managed to have 31 complete the 3-month follow-up and 28 complete the 6-month follow-up. And so of the factors that we were looking at shown on the previous slide, 6 of those 11 factors demonstrated significant improvement. Most of these were subjective, which we'll show in a second. And of the objective factors, the one that showed significance was financial needs met. So there's obviously an improvement in a lot of these quality of life factors. So here's a table for our objective factors. And all of these, we saw improvement. The only significant improvement that we saw was in financial needs met. And here is a table for the subjective qualities, most of which improved. And what's to note here is that even the ones that may not have actually hit significance, we actually did see improvement in, especially with the objective factors. Housing, homelessness decreased by a lot, however, did not meet significance. And employment also increased. So, very important. However, we kind of think that in our short time frame of just 3 months to 6 month follow-up, it may not have been quite enough time to actually show significance in these objective factors. For instance, especially and take something like education. Most of our patients in 3 or 6 months may not go and get a higher degree in that time frame. Or homelessness, they may not have all been able to buy a house. But what we're looking at is on down the road in future studies, increasing this time frame from 6 months to maybe 18 months or even longer to see, just how effective this treatment plan is, this emergency department initiated MOUD, not just at improving quality of life, but also just being effective, decreasing drug use and relapse and all the other associated factors. And so in conclusion, in addition to decreasing illicit opioid drug use, the maintenance of emergency department initiated MOUD may positively impact broad quality of life measures. And those measures may even improve even furthermore in future studies that have a longer time frame. And with that, keep it short and sweet. I will open the floor to questions or discussion.
Great. Thank you, Caleb. I love this project because it looks at more than decreased death rates. It's actually looking at what are we doing for their quality of life. And I think it gives many of us who do this work an additional kind of boost to feel that we are definitely doing the right thing and maybe take the extra time to do this.
Yes,
what questions do we have from the floor or the Zoom rooms? I have one comment. I'm really impressed by your follow-up rate. 44% 6-month follow-up rate is really good for these kind of studies. Many of these folks are not easy to find. So I'm really impressed with that.
We actually were too.
How did you get that high rate? Like how did you do that follow-up? Did you send people out to people's homes? Did you call them?
I would really, this is a question where Dr. Walter would probably be able to give you an exact answer, and I've actually thought about this too. Why was ours so much higher? And what we think, and there's a lot of factors going in here, the big one actually being, I think, COVID-19. It really affected emergency department opioid use disorder patients. That population affected in a weird way because obviously we saw during COVID, the total volume of emergency room visits went down, and that included OUD patients. So what we think is that, and to enroll in the study, you actually have to come in. And so what we think is the patients that did come in, they might have been, more motivated, more dedicated to improving than maybe patients in a non-COVID setting.
Mm-hmm.
And that might have aided to the retention rate.
Mm-hmm.
If there are any other details,
yeah,
I'll be sure to ask Dr. Walter on that.
Yeah, no, I'd like to replicate your methodology then, except for COVID. I don't want to repeat that one.
Right. Yes, ma'am.
Great. All right. Well, thank you very much.
Thank you all. You have a great day.
Our next presenter will be Dr. Misha Bandari on the topic of factors associated with compliance to outpatient follow-up visits after discharge from the emergency department. Do we have Dr. Bandari here? Okay. What we will do then is we'll go on to the next talk, and then we'll go back if we get a chance to. And the next one will be Dr. Ethan Forsgren, who will be speaking about perspectives on the ED initiation of MAT for alcohol use or medical assisted treatment.
Yes. 1 second while I pull up my slides.
Got as much time as you need.
Can you see my slides?
Yep, perfect.
All right. My name is Ethan Forsgren. I'm here to present provider perspectives on emergency department initiation of medication-assisted treatment for alcohol use disorder. So I know we've been speaking about opioids a lot, but this is actually alcohol that we're talking about now. I'm presenting with along with my colleagues Thibaut, Cassie, Inanna, Maureen, and Brina. We have no financial relationships with the parties that manufacture or distribute naltrexone, which is important because naltrexone is actually the first-line medication for treating alcohol use disorder. This study is made possible in part, I want to acknowledge, though, by the short-term training program at our School of Medicine, which supported our medical students' participation, which was crucial. Alcohol use disorder is a frequent diagnosis in the emergency department and the third leading cause of preventable deaths in the United States. 17.8% of adults experience alcohol use disorder at some point during their lifetimes. It leads to more than 88,000 annual deaths, not to mention an untold physical, financial, and emotional burden of disease for the patients and their families. Of those affected, it is estimated that less than 10% are ever treated with appropriate medication. And this study was built on the premise that the ED may represent a missed opportunity to initiate treatment for patients with alcohol use disorder. The first aim of the study was to identify barriers and facilitators that providers perceived in the emergency department to the initiation of medication-assisted treatment. The second aim was to take those barriers and map them to potential interventions in an effort to modify providers' behaviors. We used a semi-structured interview guide to conduct qualitative interviews with ED staff in order to identify barriers and facilitators. Subjects included doctors, nurse practitioners, nurses, supervisors, caseworkers, and importantly, our social workers, substance use navigators, and pharmacists. We used purposive sampling to generate a diverse sample by provider type, and interviews were conducted unto the point of thematic saturation in the group as a whole. Interviews were recorded, transcribed, and coded using both inductive and deductive approaches, using constant comparative analysis between multiple coders. And finally, barriers were mapped to intervention functions using the behavior change wheel, which is something I'll talk about more later. The setting for the study was the Olive Medical Center, which sits on the base of the mountains here at the northern edge of the Los Angeles metropolitan area. Many times, we'll actually have ranchers ride horseback over these mountains and tie up outside of our emergency department. Olive Medical Center is an academic medical center. It's a public hospital as well. It sees an annual census of about 60,000 patients. And the emergency department has dedicated pharmacists and social workers that are available 24 hours a day, 7 days a week, as well as a substance use navigator during business hours. This study was born out of an attempt to expand the substance use services actually offered in our emergency department. Allview established a bridge clinic in 2019 in order to refer patients who had been initiated with buprenorphine in the ED. The inspiration to add naltrexone came from Highland, where they were piloting prescribing naltrexone for alcohol use disorder out of the emergency department, which was a new setting. Highland's bridge program conveniently fits with their city's landmark. I guess you could say ours is something more of a Camino than a bridge. The study uses an implementation science framework and was conducted in parallel with the implementation team. Some of the investigators were part of this implementation team and some were solely part of the research team. Some of them, like myself, overlapped. The behavior change wheel that we were using, and I mentioned before, is a framework used in implementation science that has been used successfully in the healthcare setting. At its core, the behavior change wheel is centered around the COM-B theory of behavior change. I'm not a fan of acronyms, but this one we found useful. The COM-B model assumes that an agent's behavior, B, is the result of their interaction of their capabilities as an individual, their opportunities to act in the system, and their motivation to do so. Once a theme was identified, it was categorized as one of these three, either a capability, opportunity, or motivational barrier. And then the behavior change wheel actually recommends potential intervention functions. In this first row in red, you could see things like education, enablement, training or modeling, environmental restructuring. And it also may connect that barrier with even broader changes like legislation or changing guidelines. Ultimately, 25 interviews were conducted. Interviews ranged from 8 to 32 minutes long. Analysis utilized 72 different codes, applied 1,400 times across 600 excerpts. And once consolidated, we identified 19 specific barriers and 5 facilitators not all of which we'll have time for today, but I want to focus in on a few of them. Notable barriers included lack of knowledge about naltrexone and alcohol use disorder treatment. Among emergency providers, this was quite new to many of us. Lack of ability to identify patients with alcohol use disorder, and especially to discern their stage of change or readiness to accept treatment. Those two might be identified as capabilities of the individual, you'll note here on the right side, whereas things that affected their opportunity of agents in the emergency department to initiate naltrexone included ambiguity and responsibility between the provider and social workers for who was responsible for screening and assessing readiness for treatment, lack of resources among our patients, especially phones for patients, in order to coordinate follow-up. Should I prescribe something that a patient may not be able to follow up with their primary care doctor or get refilled? Sense of futility among providers regarding their ability to affect change with patients with alcohol use disorder affected their motivation. All things that also affected their motivation included stigma against patients with alcohol use disorder as being either uninterested in treatment or unworthy of providers' time given the other acute demands in the emergency department. And finally, resistance to chronic care was a theme among some providers who resisted the move towards chronic care and substance use in the emergency department setting. If we take one of those barriers, for example, lack of knowledge about naltrexone, you can see how it's exemplified by the quote, "I just don't think that a lot of us feel very comfortable with naltrexone because we don't really have a lot of training in it. It's not something that's covered in the medical school, and it's not something that we currently do in the emergency department instead of resident." As I noted, we categorize this as a capability barrier for the study and linked it to 3 example interventions here: education through lectures at our grand rounds and faculty meetings, the creation of actually an alcohol use disorder order set within our electronic medical record that pre-populated prescriptions and dosages, and then guidelines that we actually published throughout the DHS system here in Los Angeles in order to allay some administrative concerns about using naltrexone for alcohol use disorder in a new setting. Ambiguity of role between provider and the social worker was an ongoing confusion that affected the provider's opportunities to begin treatment. A lot of times the providers consult us without asking the patient, and we, the clinical social workers, show up and they're like, "Why are we here?" said to one of our social workers. This is an ongoing conversation, but made it painfully evident that we needed to clearly define the roles and responsibilities of providers and our social workers and substance use navigators, and who is responsible for introducing the idea of medication-assisted therapy and perhaps motivational interviewing of the patient forward through stages of change. Finally, stigma against patients who use alcohol is exemplified perhaps by the quote, "There's that coarse and vulgar term that goes metabolized to freedom," where you try to get them to the point where clinically they're sober enough to leave the clinical state and they're safely able to discharge. This affects our providers' motivations to engage with the patients and discuss possible treatment. And we actually came up with one intervention here I'd like to highlight, which is modeling an alternative to encourage screening instead of using metabolized to freedom, perhaps metabolized to screening. It wasn't all barriers. We did note some facilitators specific to our clinical setting, including weekly grand rounds for education of providers, daily nursing huddles that we were able to join to introduce this new medication to them as well, that we had pharmacists available to help us with prescribing a medication that was unfamiliar, and that we had substance use treatment centers in the area for referral to treatment. And then generally, this another facilitator was the fact that we were building on a successful implementation of a buprenorphine and bridge program that had been well received by staff and shown to be possible and feasible. In discussion, an enormous evidence practice gap exists for the treatment of alcohol use disorder. As mentioned, only 10% of people ever begin treatment with medications. The ED represents to us a missed opportunity to initiate treatment, and this study describes barriers and facilitators that our providers perceive in initiating naltrexone in the emergency department. It also describes candidate interventions specific to our clinical setting. We think implementation is improved by using this implementation science framework, and we have implemented these interventions and are embarking on a second phase of research now, looking at patients' perspectives on naltrexone use, prescription practices after these interventions among our providers, as well as patient-centered outcomes. Limitations to our study, of course, include that it's a single center study limiting its external validity, and the fact that no patient perspectives were included at this stage of the implementation design due to COVID restrictions. It was difficult to enroll patients. In conclusion, there are important barriers and facilitators associated with the introduction of medication-assisted treatment for alcohol use disorder in the emergency department. However, using an implementation science approach, we constructed a multifaceted intervention plan rooted in behavioral theory that can leverage this opportunity in the emergency department to close the evidence practice gap. Myself and one of our med students, Thibaut, are corresponding authors here. Feel free to reach out, and we'd love to share and learn from you too if you have suggestions.
Thank you very much, Dr. Forsgren, for that presentation. I really love the idea of using implementation science, and I love the behavioral change wheel, which I was not familiar with. And I think that places should use this more often. You know, we often implement changes that we think will be good, we know will be good, and then they fail and we wonder why. So I think this is really great, and I hope you get this out there, and I look forward to reading the article. I hope you're already writing it.
It's nearly done, just need to submit.
Excellent.
Yeah.
What other questions do we have for Dr. Forsgren from the audience? Nobody's curious?
So I'm not a clinician, so this may be a pretty obvious question, but I'm curious because it seems like what you're finding is a little bit different from, for instance, like medication-assisted treatment for something like opioids. Like, why do you, is that true? And if so, what do you think is driving that? I mean, that trend.
Are you referring to perhaps like, I guess a lot of them I provide a resistance to like making it a site for chronic care. I think part of it is similar to opioid use disorder, actually, because I didn't see too many broad stroke differences. I think, you know, with opioid use disorder, I think initially when it started, there was also a lot of resistance to using the emergency department to initiate treatment for opioid use disorder. And we're just in a similar stage of change as a health system now with alcohol use disorder.
Great. Are there any other questions for Dr. Forsgren? And do we have Dr. Bhandari here? I don't see the name. All right. Well, I want to congratulate all the presenters today. Excellent, high quality group of presentations. I hope you all go home and feel motivated to write these up and submit them to journals. And this concludes this session. Thank you all for participating. Have a good afternoon.
Thank you so much.
Thank you.